This presentation looks at osteodisaffiliation. The aims of this presentation are: define the term osteodisaffiliation, classify the causes of osteodisaffiliation. Our objectives will be to recognize the clinical stages and signs of osteodisaffiliation, and distinguish between the terms osteofixation, osteointegration, and osteodisaffiliation. Now, a question that is commonly asked by dentists and their patients is, why did the implant fail? And it's important that the dentist understands the reasons behind the failed osseointegration process. The first thing to fully appreciate and take on board is that the implant in itself is an inorganic device. It's a metal screw, it's an orthopedic screw, which is inserted into the patient's jaw bones to support a functioning restoration. That is all it is. An implant itself cannot fail because it's just a screw, unless it fractures in some way, but that's a mechanical breakdown, not a biological breakdown. So implants do not fail. What is happening in this process is that the patient's bone has not attached or failed to support a functioning implant. That is merely the situation which is occurring, and this phenomenon is perhaps best described as osteodisaffiliation, which means basically a failure of the bone to either attach in the first place or remain attached to the bone during function. It's important to differentiate between osteodisaffiliation and failed implant treatment. Failed implant treatment usually occurs as a result of iatrogenic problems, either poor aesthetic outcome, unrestorable badly positioned implants, or damage to the adjacent teeth and vital structures. So this is a failure of treatment outcome. The implants themselves may be fully integrated or exhibit good osteofixation and the bone fully able to withstand occlusal load and function. However, the restorative outcome is suboptimal, either in terms of function or aesthetics, or perhaps damage has been caused to adjacent teeth and vital structures such as nerves or the sinus cavities. Now, these problems are usually complications of treatment and arise as a result of operator error. At this point, it's well that we remind ourselves of what osteointegration means. It is the direct structural and functional connection between ordered living bone and the surface of a load-carrying implant. Now, the most important part of this definition, as previously mentioned, is the fact that we're looking at a load-carrying implant. Now, this definition, although it still holds true, things have moved on. And of course, dentists are now immediately loading implants. Now, implants that are immediately loaded, can we term these as osteointegrated? Well, no, because these implants are relying purely on the mechanical attachment of the implant with the bone. It's not a biological process, it is purely mechanical, and it is sometimes termed primary fixation. And what we're trying to achieve is secondary fixation, which is osteointegration. So osteointegration is actually the attachment of the bone to the surface of the implant, which is different to an implant being just screwed into the bone and being mechanically supported. So nowadays we can have load-carrying implants which are not osteointegrated, and in fact will not become osseointegrated for at least 4 to 6 months into the healing process. It may well be that in certain areas of the jaws, in particular in the anterior mandible, that the implants never truly osseointegrate, and what we're relying upon is primary fixation, a mere mechanical fixation of the screw to the jaw. What is meant by osteodisaffiliation? Well, it's the exact opposite, in fact, of osteointegration. And it's the absence of a direct structural and functional connection between ordered living bone and the surface of an implant capable of carrying load. So in this definition, we don't have this connection between the surface of our implant and the bone. Also importantly, it includes an element of function in the same way as osseointegration includes the ability of the implant to carry load. In this situation, our implant is incapable of carrying load. Now, the reason I make this distinction, as I've said before, is because we are starting to load our implants immediately. Obviously, there isn't at this point a biological connection. So our definitions have to start considering the point that we're not actually able to demonstrate any kind of biological connection until sometime into the healing process of at least 4 to 6 months. So during this period there is going to be hopefully a gradual transition from a mechanical kind of connection to a biological kind of connection. And this takes a period of time to achieve. So we start with a purely mechanical situation, and we slowly move towards a biological connection. It's important to perhaps take a moment just to consider this new terminology, and that is osteodisaffiliation. This is when the bone has failed to form direct contact or maintain contact with the surface of a load-carrying implant, resulting in implant loss. Osteodisaffiliation takes into account also that osseointegration may never have actually been established in the first place, and this is the situation with immediate loading. We have no biological connection between the surface of the load-carrying implant and the bone. So a very different concept on the way of looking at the methods by which the bone supports our load-carrying implant. Now, there are two types of bone connection with an implant. In the first, the connection can be called osteofixation. This is primary fixation, and it's mechanical connection. There's no biology involved in this process at all, and this is akin to immediate loading of implants. It is basically, as I've said before, the screw into wood scenario. There's no biology, it's just a straight mechanical connection. Obviously, what we're hoping is that with time this mechanical connection will move on to osteointegration, which is secondary fixation, and now this is a biological connection, and this is what we will hope will develop from our osteofixation, is that we will move on to osteointegration over a period of time. Osteofixation is most likely to be a short-lived phenomenon. If we do not get osteointegration, then most likely the bone will undergo osteodisaffiliation, and we will end up with loss of our implant. So this is what we hope will happen. We'll go from primary fixation to secondary fixation. Now, the way in which we achieve this, there are different protocols, and we'll be looking at these in more detail. One is a delayed protocol, and the other is an immediate loading type of protocol. Now, there are also types of implant function which depend on the type of bone connection to our implant. So we have the delayed loading protocol. This is placing the implant out of function, either by just keeping it out of the occlusion or by burying the implant under the patient's gum. These are both ways in which we avoid loading the implant, and this is a technique where we try to establish the biological connection, osseointegration, and it's often used in areas of high load or in areas where the bone has got poor mechanical properties such that it cannot deliver the level of primary fixation required to withstand occlusal loading. So delayed loading, and this is often the safest protocol, and especially when you're starting off with your implantology practice, you should be considering delayed loading protocols only. Now, moving on from this, we have immediate functional loading, where the implant is placed into the occlusion. It's sometimes difficult. You can have an infraocclusion where you slightly keep the prosthesis out of the patient's occlusion, but the implant nonetheless is still functioning. As soon as the patient puts a bolus of food or material between the teeth, they are in function, and the implant will be taking load, and that load will be transmitted to the bone and the bone connection interface. So as we can see, this protocol is not a biological protocol, it's purely a mechanical protocol, and it relies entirely on the mechanical characteristics of the bone to withstand the load, and also to a certain extent the biological ability of the bone to repair and regenerate itself and maintain a contact with the surface of our implant. And that's not the same as developing osseointegration. Osseointegration takes at least 4 to 6 months to develop. Immediate loading is immediate and relies totally on this mechanical fixation of the bone. So I cannot overemphasize the difference between the two approaches and what you're relying upon in order to support your implant. With the advent of immediate loading, it's important that dentists should understand what is happening biologically to the bone and what the situation is with regards to the type of attachment or fixation of our implant. So if we're intending to immediately load our implants, what we're relying upon is primarily a mechanical implant fixation. This is just the screw into a piece of wood scenario. There is no biological element to this process. There is purely a mechanical fixation of a screw into wood. Now, over the functioning time of say 4 to 6 months, this process of osteofixation will turn into osteointegration. Now, this is a secondary biological implant form of fixation, and this normally starts to become stronger after a 6-month period, and then is a dynamic process which is continually changing and altering in response to the loading or the bacterial environment and challenges. So we have these two types of fixation, starting with osteofixation, which is mechanical, moving on to osteointegration, which is biological fixation of our implant. It's a biological attachment. Now, of course, during this period, should the implant not be able to function and has to be removed, well, then we've got a situation of osteodisaffiliation, which is the failure to either develop or form this biological attachment of osteointegration. So considering the terminology more closely, osteodisaffiliation is the inability of the host bone to deliver and maintain direct contact with a functional implant. So this definition does not take into account any biological connection or attachment between the surface of our implant. And the reason for this is because with the recent advances of immediate loaded implants, it is not possible to demonstrate or to be able to show a biological connection as occurred with osteointegration. With these immediately loaded restorations, they cannot be said to be osteointegrated as they haven't had time to form the biological connection, and as such there is just a mechanical connection. And the term osteodisaffiliation is confined to situations where the bone, for one reason or another, has not been able to maintain or achieve this direct contact to the surface of an implant so that it can function as a retaining device for a occlusally loaded restoration. So what are the consequences of osteodisaffiliation? Well, ultimately we can end up with the loss of an implant. Remember, avoid the term a failed implant. The implant is lost rather than failed. It's either lost its function or it never achieved function, and this is down to osteodisaffiliation. Now, the other consequence of osteodisaffiliation is the loss of bone, and this is perhaps more serious than the loss of an implant. An implant can be repurchased very easily, however bone has to be regenerated, and this is both costly and unpredictable. Remember, grafting and the regeneration of bone is not a procedure which produces guaranteed results. There can be failures, there can be rejection of a graft, there can be infection of a graft, and even after you have regenerated bone, this is often a bone-like material. It's not exactly the same as the patient's host bone, and so the response of any implants placed into that grafted area is again questionable and may be associated with lower survival rates. So at all costs, please try to preserve the bone, and if you are aware of osteodisaffiliation, perhaps the best treatment of all is to remove the implant as soon as possible in order to preserve the bone. Now we're going to be looking at a classification for osteodisaffiliation. This classification is based on the etiological and iatrogenic factors responsible for osteodisaffiliation, which is the result of a multifactorial process that can occur at any point following implant installation and function. Now, this classification has been devised to take into account the new processes of immediate implant loading, which was never considered previously. The earlier protocols actually prohibited immediate implant loading and took great steps to avoid inadvertent loading of our implants. Obviously, immediate loading is a complete 180-degree about turn, if you like, from this protocol, in that we are going to be loading our implants immediately. So this types of osteodisaffiliation are considered in terms of loading. in the past as well, people have considered definitions of failure based on whether it's an early or a late failure. I think this type of classification based on the functioning position of the implant or status of the implant is perhaps more applicable in today's environment. So we're looking at osteodisaffiliation types, and we have a non-functional osteodisaffiliation, and this is if you like, failure to maintain bone at any point prior to function. These implants will have never achieved osseointegration. So this type of non-functional disaffiliation takes into account those situations where an implant is lost relatively early in its functioning life. It's actually a non-functioning life rather, in that the implant has just been inserted into the bone, hasn't been loaded, and maybe it's lost fairly early on because of infection or rejection by the patient of the implant for some reason. So the first one is a non-functional osteodisaffiliation, and it can occur fairly early on in the process. Now the next one is a functional osteodisaffiliation. So this is where implants have been loaded and they've exhibited, at least initially, good functional stability for some period of time. So this takes into account failures which would occur of the bone when it is immediately loaded. Now you'll notice that I'm avoiding the term failed implant and I'm using the terminology failure of the bone. So in this situation, the bone has failed to deliver a contact such that it can support a functional implant. We're not considering whether we've got osteointegration, because obviously, as I've said before, if an implant is loaded immediately, it most definitely is not osteointegrated, it is osteofixated, which is a completely different situation, a mechanical one. So we're looking at osteodisaffiliation. There's two types, non-functional and functional, depending on whether the implant is being loaded or not loaded. It's important to appreciate that osteodisaffiliation can occur at any point during the history or life cycle of an implant. It can occur before the implant is loaded or after the implant is loaded. So the failure of the bone to maintain a direct contact with the surface of your implant can occur at any point. It can occur after integration has actually occurred and has started to degrade and fail during function. And the reasons for this osteodisaffiliation, or the lack of a continued contact with the surface of an implant able to carry load, is multifactorial and can be broken down into either biological or mechanical reasons. And as I say, this can occur at any point during the life cycle of the implant, either before it's brought into function or after it's been brought into function, or even after it's been in function for many years. So I think it's important to take on board that there is no single reason for why an implant may be lost as a result of osteodisaffiliation, and it may also be possible, or is often possible, that this loss of the implant is due to a number of factors combining and working together, and not just one factor. Now, in the following lecture, we're going to look briefly at each of these factors, but during the coming program, you will be looking in more detail at each one. We've considered general medical conditions in previous presentations, but I think it's useful to just look again at perhaps the main ones, and it's always tempting to find obscure medical conditions for why we may get osteodisaffiliation or loss of an implant. However, at the end of the day, there are pretty common conditions which we are going to be expecting to see in general practice, and in fact in certain parts of the world these conditions are more prevalent than others. I'm looking at particularly diabetes here, which is on the increase in the West and has a high percentage of patients in the Middle East do suffer from this condition, either type 1 or type 2. Type 1 is considered a more severe risk than perhaps type 2 diabetes, but both of them have to be taken seriously. So diabetes is particularly considered an independent risk factor for the development of surgical site infections, and this risk increases with regards to the size of the procedure that you're taking on, the size of the wound that's produced afterwards, because this will require more healing. If you have a large wound, it's obviously going to take longer to heal, and then if you're going to do diabetes in combination with grafting and implants, you can see that this independent risk factor becomes more important. So on its own, it's not particularly a risk, but when you combine it with other risks such as the size, the duration of surgery, the complexity of surgery, if there's any graft procedures or membrane procedures, if the patient has any other conditions like they're a smoker or osteoporosis, then this independent risk factor becomes more significant in the whole equation. Now again, osteoporosis, this is a condition which affects the strength of the bone, and again is an independent risk factor. It of itself may not definitely cause an implant failure, but we need to be aware of it and take it into consideration if the patient has other conditions such as, say, diabetes. And then finally, we've looked at medication, and in particular we are concerned now about the antidepressants, the selective serotonin reuptake inhibitors. They have been shown to increase the chances of implant loss, or as I prefer, osteodisaffiliation. Other drugs such as bisphosphonates, which are used to treat osteoporosis, and even oral bisphosphonates have been implicated in the breakdown of bone and the loss of a functioning implant. Even after the implant has been in function for many years, we can get loss of function. Remember, osteointegration is a living process, it's a dynamic process. It's not a once and for all thing. It can break down and it can be lost at any time during the life cycle of that implant. Now, another thing which will affect the quality, the biological quality of our bone, is the patient's social habits and addictions. And of these, smoking is perhaps the most serious and prevalent risk factor. So in the West, if your patients are smoking, then really think twice. Definitely in the Middle East, if your patients use shisha regularly, I have found that this is a major cause for osteodisaffiliation. It also results in delayed wound healing or even dehiscence of wounds, and definitely graft procedures in such patients are very difficult to manage. So smoking in patients is to be discouraged, and I would strongly advise that you have the patient stop smoking for ever, if they're having implant treatment. Some doctors feel that if they stop the smoking for a few days before the surgery and a few days after the surgery, then this is okay. No, remember, osteointegration is a dynamic, lifelong process, so anything that will affect the general health of the bone at any point during the patient's life will also affect osteointegration and could lead to osteodisaffiliation. Again, alcohol is a problem. In the early stages of treatment, it can cause wound breakdown, but it also affects the biological quality of the bone and the ability of the bone to carry function via an implant. So these two social habits, which can be addictions, are very important to consider. And obviously, again, if you have a patient who has a combination of smoking, alcohol, and put on top of this diabetes, we've got a serious problem, and the chances of implant survival are, in my opinion, absolutely negligible. And to provide implants to patients with these set of conditions is prone to or doomed to failure, and you really shouldn't go ahead and treat patients who aren't suitable for implant treatment. Now, when it comes to host bone quality and quantity, we can start by looking at the quantity, which is the volume of the bone on hand, and we're looking at things like the depth and width. And the best way, as we've covered in previous lectures, is if you're in any doubt about the quantity of the bone, is to take a CBCT. Now, it may be possible to increase the quantity of the bone by using grafting procedures, but remember, the bone that you produce isn't going to be of the same biological quality as the patient's own host bone. And this is why techniques which involve either placing the implants into different anatomical areas or the use of bone expansion and dilation techniques may offer some improved chances of outcome. Although this is absolutely not definite, it's worth considering. Wherever possible, it is normally accepted that the gold standard for bone is the patient's own homegrown bone. So I think the thing to remember here is homegrown bone. There's nothing better than homegrown bone for our implants. If you introduce any other type of bone, the prognosis is less reliable and less predictable in terms of treatment outcome. When we look at the quality of bone, often in implant dentistry, we look at the quality of bone in terms of mechanical properties. That is, how able is the bone to provide good mechanical primary fixation of our implants. And this particular feature of bone is very important when one is considering any form of immediate loading. Immediate loading is contraindicated in sites where the bone has a poor quality, that is, does not deliver a high primary stability, and this is often done by measuring the insertion torque of the implants, and often torque values in excess of 60 Newton centimeters are required to provide sufficient stability to allow for immediate loading. And remember, when we're doing immediate loading, there is no biological attachment. There is just a functional connection, if you like, between the bone and our functioning implant. The biological properties of the bone, however, are a different matter, and they are dependent on things such as the patient's general health. And predisposing all health as well. So we have biological properties and mechanical properties, and they're both important when it comes to assessing the patient's bone quality. So at the end of the day, if our patients have poor bone quality or lack of bone, that is bone quantity, then again you can expect to have a higher chance of implant loss or osteodisaffiliation, which is the failure of the patient to maintain some form of functioning contact between the bone and the implant. Grafted sites. As I've said before, it has been shown that implants are more successful in host bone than in grafted bone, and this has been shown in numerous studies. And again, many clinicians think that bone is easy to graft, it's easy to regenerate, it's easy to produce, whereas in fact the opposite is entirely true. It's very difficult, it's very unpredictable, and when you do produce the bone, it's been shown to produce less successful outcomes or treatment outcomes in implant dentistry than the patient's own bone. And the other thing to remember is that grafted bone may not be stable and it can resorb over time. So even though you produce a good result, sometimes when we look back at this bone after 4 to 5 years, we find that it has resorbed to perhaps half or even less than its original value. So often in graft procedures, surgeons overgraft the site to try and compensate for the loss of graft bulk over time. Now, infective osteodisaffiliation. Infections during the first 3 to 9 months and complications occur like swelling, fistulas, suppuration, and you can get early or late mucosal dehiscences. This is due to flap breakdown, or can even occur because a restoration is resting on the gingiva, submitting it to trauma. You can get infections of the bone, osteomyelitis, and these may be indicators of osteodisaffiliation. Signs of infection occurring in the early stages after placement are said to be more critical than if they occur at a later stage, because it will lead to disruption of the osteointegration process. So if you get these infections occurring quite soon after placement or prior to loading, then of course this will put into question whether in fact you're able to achieve or maintain osteointegration, and in fact you will have osteodisaffiliation. And these are particularly prevalent if you're considering again early loading of your implants. If your implants become infected for any reason during the early loading stage, you must immediately disconnect the restoration and bury the implants because it will be very difficult to treat an infection in bone around a loaded functioning prosthesis. Now, infective osteodisaffiliation can occur quite late on in the functioning life of your implant, and the most common one is peri-implantitis. Perhaps a better description is peri-implant disease, and this is nearly always down to poor oral hygiene and patient maintenance, and at least 10% of failures have been suggested to be the result of peri-implantitis. So it's quite a significant cause of infective osteodisaffiliation. And there's a lesser known condition of retrograde peri-implantitis. Now we'll be discussing this and peri-implantitis in more detail in coming presentations, but a retrograde peri-implantitis looks rather like periapical pathology on the root of a tooth. However, it has got different causes and different possible treatment regimes. Now, infective osteodisaffiliation resulting in implant loss is commonly associated with streptococci, anaerobic gram-positive cocci, and anaerobic gram-negative rods. And these are essentially the same microorganisms which are associated with periodontal disease. Now, when we look at antibiotics in dental implants, a review of the literature, this article was published in 2016, and this article proposed that to achieve high long-term survival and success rates of dental implants, antibiotic prophylaxis is required. Now, this is a common problem that seems to occur, and it is the fact that a lot of dentists forget to prescribe antibiotics prior to implant treatment. They give them preoperatively, and they also give them in insufficient doses. So this is a iatrogenic example of implant loss and osteodisaffiliation. It is most important that prior to placing an implant that you ensure the patient is given the correct antibiotic prophylaxis. A literature review conducted on the effect of antibiotic usage on dental implants has shown a success rate of 92% when no antibiotics were used, 96% when prophylactic antibiotics were used, and 97% when post-operative antibiotics were used. So we can see that there is evidence in the literature out there to support the effectiveness and the need for antibiotics. So one of the first questions I ask anyone who says, well, why did this implant fail, is, did you provide antibiotics? And if so, when and for how long? Now we'll look at this a little bit more detail in the coming presentation. Principles of prophylactic antibiotics. Now, the first one is the procedure should have a significant risk for an incidence of post-operative infection. So, obviously, patients who are diabetics would be a significant risk of post-operative infection. But of course, any procedure that you carry out where you produce a bacteremia, which is produced just by cutting the tissue, you're going to produce a bacteremia. It's going to be subject to possible surgical site infection. And we're going to look at this in the presentation in a little bit more detail. And you need to use an appropriate antibiotic should be selected. And that means that also the dose should be effective and appropriate. Often patients are prescribed 250 milligrams of a particular antibiotic, and whereas this may be sufficient to manage an existing infection, it is not sufficient to prevent a bacteremia and to negate its effects. And for prophylactic cover, the doses have to be far higher, because you have to deliver or develop high serum levels of the antibiotic prior to the procedure in order to protect the site and also to prevent contamination of our implant. One of the reasons it is suggested that prophylactic antibiotics improve the survival of implants is that it prevents contamination of the implant surface with bacteria during placement. So an appropriate tissue concentration at the time of surgery is necessary, and that will not be achieved by giving 250 milligrams of an antibiotic after the procedure. It has to be before the procedure, and it has to be at a high dose. So, use of shortest effective antibiotic regime. Now, antibiotics do not necessarily have to be carried on, prophylactic antibiotics. It's not like treating a pre-existing infection where if you stop the antibiotics too soon, you will run the risk of a recurrence of the infection or even developing resistant strains. No, that is not the point of prophylactic antibiotics. The point of prophylactic antibiotics is a sharp one-hit concentration of antibiotics purely aimed at preventing infection. We haven't got an infection. We shouldn't be operating in an infected site. So to begin with, our patients are healthy. They are not infected. They do not have a jaw infection. We are not treating a jaw infection. We are trying to prevent one from starting, and we are trying to prevent contamination of our implant surface to improve survival and reduce the risk of surgical site infection. So the two protocols are entirely different, and so giving patients normal therapeutic doses of antibiotics is a complete waste of time and ineffectual. In fact, you may as well not even bother giving the patient any antibiotics at all if you're deciding to take that approach. Now, one study looking at the significance and importance of prophylactic antibiotics to implant treatment came up with the following conclusions. Antibiotics are beneficial for reducing failure of dental implants placed in ordinary conditions. What is meant by ordinary conditions? Well, the patient isn't suffering from debilitating medical conditions or has severe pre-existing infections or other reasons why the implant would not respond as expected. They suggested a 2 grams of antibiotic in a single administration 1 hour preoperatively significantly reduces failure of dental implants. They also said it's unknown whether post-operative antibiotics are beneficial and, in fact, which antibiotic is most effective. So let's look at the antibiotics, and again we're going to be covering this topic in more detail in the preoperative management of our patients during this course. But one of the factors I would like you to look at now is elimination half-life. Now, this is the time it takes for the concentration of the drug in the plasma or the total amount in the body to be reduced by 50% of the original dose. So in other words, if a patient takes 100 grams of an antibiotic, at what time after taking the antibiotic would we expect the dose in the tissues to be reduced by 50%? Now, this is very important when it comes to calculating the initial dose and how often it should be replaced. So let's look at this in a little bit more detail. So let's look at amoxicillin. Elimination half-life is 61.3 minutes. Approximately 60% of an orally administered dose of amoxicillin is excreted in the urine within 6 to 8 hours. Now, in fact, it's quite interesting to note that the antibiotic is not metabolized, it's actually excreted. So originally, when antibiotics were in short supply, the hospitals used to recoup the antibiotics from the patients by filtering their urine. So from our point of view, this explains why it's necessary to repeat the therapeutic dose every 6 to 8 hours, because after 6 to 8 hours your dose is significantly reduced. So you can see that giving a patient 250 milligrams of amoxicillin would mean that within 6 hours the effect of that would be 125, which is probably below its any therapeutic advantages it may deliver. So this is why we give high doses, because we know within 6 to 8 hours that 3 grams or 2 grams of amoxicillin is going to be down to 1.5 grams, and then another 6 to 8 hours after that it will be down to 750 milligrams, so on and so forth. Right, so detectable serum levels can be seen for up to 8 hours after oral administration of amoxicillin. And remember, this is a bactericidal and it's broad spectrum. Now we're going to be covering the significance of this in later lectures, but remember that amoxicillin is almost like a machine gun of antibiotics. It will kill, devastate any bacteria that are in its path. It's very broad in its action, and this means that commensals will also be lost, as well as the bad guys. And this antibiotic is particularly prone to causing diarrhea. All antibiotics can cause this, but this one is particularly prone. It doesn't interact well with alcohol, although it can be taken with alcohol. Its nauseous effects and diarrhea will be increased, and obviously one does not want to submit our patients to unnecessary discomfort following the procedure. And I have had on occasions patients very happy with the implant procedure, but complaining that they felt very unwell afterwards, or complaining in fact that they had a very uncomfortable 2 days suffering from severe diarrhea which prevented them from going to work. And this is not the kind of feedback one really wishes to hear from our patients. Augmentin, which is very popular, this has a half-life after oral administration of about 1 hour again, and that's the half-life of amoxil. And it also has added to it glavulanic acid, and that has a half-life of again 1 hour. So 1 gram of augmentin is going to have an effective half-life of 1 hour. So after 1 hour, our augmentin is down to half the dose, so it drops down to 500 milligrams if you like. And remember, augmentin consists of a combination of glavulanic acid and amoxicillin in the ratio of 875 grams of amoxicillin to 125 milligrams of glavulanic acid. Now the dose for this is every 12 hours if you're going to give augmentin. Now remember, in higher concentrations, or if the patient takes more than the prescribed dose, the glavulanic acid can become, well, it is in fact toxic, so they shouldn't exceed the dosage parameters. And again, this is a bactericidal type of antibiotic, and it is broad spectrum. So again, quite a heavy weapon that we're using in order to provide our prophylactic cover. Now, a drug that's less known to dentists, but is one that I prefer to use, and one which we used during the program, is 500 milligrams, and that can be delivered 30 to 60 minutes just prior to the procedure. Now, why do I like this antibiotic? Well, one, it's relatively inexpensive. Because it's not used that frequently, a resistance to it and allergies to it are quite rare. Patients normally don't report any diarrhea or nausea, although like any antibiotic it can cause these things, but I think its mode of action and the way in which it prevents bacterial growth, it's a bacteriostatic type of antibiotic which inhibits the growth of antibiotic. It's not as devastating to the patient, and because its spectrum is again narrower, it's not as devastating to the patient's own microflora, and so diarrhea and nausea I feel is less likely. And the other interesting thing about it is that its half-life is about 11 to 14 hours. It's much greater than the half-life of amoxicillin and penicillins, which are gone within 1 hour. So again, we don't have to keep on repeating the doses if we wish to provide post-operative antibiotic cover. So the dosage I find that is particularly nice here is 1 gram. And if you're going to carry on the antibiotic regime, then 1 gram once a day for X number of days is quite a nice regime for patients to follow, and it's very easy for them to manage and incorporate into their daily lives and remember to take. Now, it's most important that we produce an antibiotic regime which is tailored to the patient's needs and which is compliant with the requirements for prophylactic antibiotics cover. Now remember, there's 3 main points to prophylaxis in that the dose should be sufficient to prevent infection. That means it must have a good plasma concentration at the time of surgery. It must be of appropriate type, so that it must be effective against the antibiotics which we're trying to prevent from causing the infection. And the duration of the antibiotics after the procedure should be as little as possible or limited to just what is entirely needed and appropriate. So let's look at one possible regime, the regime that I use, which is based on these principles. There are many regimes in the literature. I have no problems with them. The literature shows many regimes to be effective, but this is the one that I find works well for me in practice. And as I say, I prefer to give azithromycin because the after effects seem to be minimal and the elimination half-life is very high indeed compared to the alternatives. So, healthy patients undergoing short duration procedures of less than 30 minutes, I find that 500 milligrams 1 hour before treatment as a one-shot time thing is perfectly adequate. What do I mean by a healthy patient? Well, I mean one that doesn't have some systemic condition or oral condition that would predispose them to infection. Right, the next one is a healthy patient undergoing longer duration procedures. Now, this is anywhere above half an hour to an hour. And again, 500 milligrams 1 hour to 30 minutes before the treatment is started and continued for 1 day after seems to be perfectly adequate. It's also a nice regime for the patients to remember because it's just take 1 tablet when you wake up the next morning. So compliance tends to be very good. If you have complicated post-operative regimes, compliance tends to drop off. Patients either forget or lose interest or don't see the importance of taking their antibiotics at all. So again, it's a healthy patient and they're undergoing a procedure no longer than 30 minutes or no greater than 60 minutes. Now, if we have a compromised patient, and what I mean by compromised patient is one that is perhaps got a systemic condition such as diabetes. Now, obviously these patients will be controlled because we shouldn't be carrying out implants on patients that don't have a controlled condition. But they are more perhaps at risk of developing surgical site infections following the procedure. So for these patients, I would prescribe the antibiotics for a little bit longer following the treatment because their healing response will be diminished. So although they can undergo the treatment, they're quite fit and healthy to undergo the treatment, their healing is delayed, and if their healing is delayed, that leaves the wound open and susceptible to infection from bacteria. So it's covering for delayed healing. Although diabetic patients also have a compromised immune system, with this approach, what we're really trying to do is compensate for their delayed healing as well as for their reduced immune system. They also have vascular problems, so again revascularization of the site is delayed as well, and for that reason antibiotic cover should be continued. The interesting thing about azithromycin or erythromycin is that it is excreted in the crevicular fluids. Now, as I've just said, revascularization is sometimes delayed in patients who have diabetes. So the question has to be, well, how do these systemic antibiotics reach the operative site if vascularization is delayed? There's no route for the bugs, for the antibiotics to reach the bugs. And this is why the fact that this antibiotic is excreted in crevicular fluid is quite useful, because it means that you get a local effect of the drug as well as a systemic effect. So now if we move on to long duration complex procedures where we have a large wound, or perhaps we're doing extensive grafting, then I would give again 500 milligrams 1 hour before treatment, and then I would carry on the post-operative cover for at least 3 to 6 days, depending on the size of the graft, how the procedure went, and also taking into consideration the health of the patient as well. So if they're at all compromised, or then they should perhaps be given longer doses of antibiotics. So you see, the regime is very much tailored to the presenting condition of the patient and to the treatment that you're undertaking. So you have to adjust the dosages and the durations according to the procedure and your patient type. Now I've done this one for azithromycin. Obviously, if you decide to use amoxicillin or augmentin, I would suggest at least 1 gram of augmentin, or if it's amoxicillin, perhaps 2 grams of amoxicillin to 3 grams of amoxicillin, and then use the same protocol as I've outlined here. I do have problems with continuing large doses of augmentin or amoxicillin, so I would drop the sort of post-operative doses of these particular antibiotics to say 500 milligrams for post-operative cover. Now, something that's often discounted or overlooked is the use of an antiseptic mouthwash. Now, chlorhexidine has been shown that if it's given immediately preoperatively, then this can reduce the chances of implant loss from 13.5 to 4.4% in patients with diabetes. So again, I think that if you have a patient that's at particular risk due to a compromised immune system or their general medical condition, or if you are carrying out a procedure that is of particularly long duration then or complexity, then using chlorhexidine and getting the patient to hold the antiseptic mouthwash in the area for say a minute or so just prior to making the incision could help reduce the chances of post-operative infection. I do not think that it's useful to give the patient chlorhexidine, a mouthwash, say 15 to 20 minutes beforehand, because during this time the area could repopulate with bacteria. I think if you give it just before you're about to make the incision, then this is the best time to give it. Do I give it to all patients routinely? No. there is evidence out there that allergies to chlorhexidine are on the increase because of its widespread use, not just in mouthwashes but also in toiletry products and washing materials and other antiseptic creams. And so there has been a reported incidence in the UK of a child developing a severe anaphylactic shock following the use of chlorhexidine mouthwash in the surgery, and the child actually died in the surgery as a result of using the mouthwash. So again, like most things, they're not to be used liberally, they're to be used thoughtfully as and when required. Now, the effect of duration does have an outcome on the risk or increased chances of surgical site infection. So prolonged operative time can increase the risk of surgical site infection. A 13, 17% and 37% increased likelihood for every 15, 30 minutes and 60 minutes of surgery time respectively. So basically, as you increase the surgery time, your chances or likelihood of infection increase by 13, 17 and 37%. On average, across various surgical procedures, the mean operative time was approximately 30 minutes longer in patients with surgical site infections compared to those in patients without. So again, it was found that those patients who subsequently developed infections following surgeries on average had surgery times which were 30 minutes longer than those who didn't develop the infections. So again, all this supports the idea that the more quickly the procedure can be conducted, reduced chances of infection. And remember, the reason we're interested about infection is because infection causes osteodisaffiliation, and our implants will not be able to carry load. We will not get a functioning connection between the bone and the implant, and we will lose our implant. So it's most important to avoid chances of infection or infective osteodisaffiliation, and we've looked at this in terms of antibiotics, pre-operative and post-operative antibiotics. We've looked at it in terms of prevention through mouthwashes, and now we're considering reducing it further by effective use of surgery time. So at this juncture, I'm going to go back to my saying, which is 5% preparation, 95% perspiration. 95% preparation, 5% perspiration. Why do I say this in this instance? Well, it's to do with surgery setup and how you organize yourself. Obviously, it's important to make sure that you have all the equipment necessary to carry the procedure at hand. Just the fact that a driving or a burr is missing can increase the surgical procedure time by at least 5 to 10 minutes. If you have multiple instances of this occurring, then your surgical time will be increased even further, and the chances of a post-operative infection increased, as we've previously seen. If you then build into this equation the fact that you've forgotten to give the patient the antibiotics, or you haven't given the patient enough antibiotics, or you haven't given them pre-operative or post-operative antibiotics, and then build into that you have a patient who maybe is a diabetic, even though they're controlled, they're still at increased risk of as an independent risk factor. With all these other things combined, you can see the chances of developing an infection which would lead to osteodisaffiliation increases immensely. So preparation is very important, and as part of this, as in this course, we produce a pre-operative checklist to ensure that you provide the antibiotics and have the equipment at hand ready to use. Now, there's also a situation of aseptic. Now, I'm going to look at iatrogenic reasons for implant loss. Again, I'm avoiding the term failure, it's implant loss. And iatrogenic means the surgeon's fault. So all these are reasons that we fail to get osteointegration and we result in implant loss is due to the surgeon. And the main problem is competency. Obviously, we're looking at restorative competency, and that goes to the type of materials we're going to restore the implant with, how we're going to manage the occlusion, also how we treatment plan, have we got enough implants to even take the load intended. Oftentimes dentists underestimate the number of implants required. It might be a free end saddle situation and they're intending to restore the posterior occlusion with one implant when 3 implants are required. Surgical treatment and management. Again, surgeons or dentists have poor surgical skills. They end up dehiscing the bone, breaking the bone, overheating the bone, removing too much bone, drilling at the wrong or incorrect angles. This means that the implants are placed in not the most optimal bone volume, and obviously this whole process relies entirely on the connection of bone to the surface of our implant, and for this to occur we must have bone there in the first place. So if you've placed the implant such that it is covered by very little bone, or you've drilled away all the bone, then you're reducing the chances of osteointegration, because osteointegration is a bone phenomenon. It is not an implant phenomenon. Implants, as I've said before, are lumps of metal. They can do nothing in themselves. We're relying completely on bone, and if you mismanage the bone surgically, you will not get osteointegration. In fact, you will get osteodisaffiliation. So, the provision of aftercare and long-term maintenance, and that can be as simple as providing antibiotics post-operatively, but also you have to monitor these patients, you have to monitor the stability of the restoration. Has the occlusion changed? Are the abutments still in position, or have they become loose? How is the patient maintaining their oral hygiene? Are they developing mucositis, or are they moving on to develop more serious peri-implant disease, and that is peri-implantitis, which is very difficult to treat and in fact has no recognized treatment regime. And bear in mind that once you have peri-implantitis, you cannot treat it. It is a lifelong. You've lost the bone. It can't be. You can't turn back the clock in that way. So very serious consequences for peri-implantitis. And as I say, these are all management issues which are in the hands of the clinician. So the question of competency nicely brings us around to looking at experience. So there's a definite learning curve for dental implant placement. Implants placed by inexperienced surgeons, those are considered to be surgeons who placed less than 50 implants, failed at 5.9%. That was twice as often as those placed by experienced surgeons, which is greater than 50 implants, and they were down to 2.4%. So the greatest difference was seen between the first 9 cases and all the others, with later cases failing significantly less. So the more implants you place past your first 10 to 9 implants, the greater your success rate. Surgeons with little or no previous experience must expect a definite learning curve. So this is why, again, many surgeons new to the procedure will experience higher failure rates, and this may be due to management issues, poor patient selection being the first and foremost, poor occlusal management, restorative management. Surgical management can be poor, surgical skills can be poor in that bone is dehisced or damaged or overheated. Patients aren't prescribed antibiotics at the correct times or dosages. There are a myriad of reasons why the inexperienced surgeon can experience higher failure rates, or in fact higher rates of osteodisaffiliation. So inexperienced surgeons will experience, unless they're very fortunate, higher rates and percentages of disaffiliation as compared to those experienced in the field. And as I say, this is not just one thing. It's not just down to poor surgical technique, as may be perceived by many dentists. It's down to, right going to the beginning, from patient assessment. Is the patient suitable for this procedure? If they're suitable for this procedure, then treatment planning. How many implants? Where do I place the implants? How do I load the implants? What type of restoration? How do I manage the occlusion going forward? You can see there are many areas where we can expect to get osteodisaffiliation, and this is why it's a multifactorial phenomenon with multiple risk factors. And as I've said previously, the main risk factor here is the experience of the clinician placing the implants, because a lot of these risk factors are known, fully understood, but if they're ignored, or even worse, they're not known about in the first place, you will expect to have high rates of osteodisaffiliation. Now, if we just look at the relationship between failure rate, experience and complexity, we're looking at higher failure rates to number of implants placed, and I've just generated these little curves. Now, we could expect that if we're doing complex procedures and protocols involving grafting on multiple implants, or perhaps in patients who are compromised, then we can expect to see higher failure rates in any case, regardless of one's experience. But if we then add on into this mix, if you like, the fact that the surgeon is relatively inexperienced, that is less than 50 implants placed, then we can expect a correspondingly high failure rate and learning curve. So we have learning curves here in red, which is for our complex procedures performed by relatively inexperienced operators, and we have the standard protocols, which is the green, and again our relatively inexperienced operators will expect higher percentages of osteodisaffiliation than our experienced operators. Now, at the end of the day, as your experience increases, then your success rate will also increase, and you will find that for complex procedures and standard protocols, as your experience increases and the number of implants increases, that you will end up with a success rate for both which is approximately equal. So experience is very important, and experience and complexity is very important. And this is why those of you starting out on placing implants should carefully select your cases which present the best possible chances of a successful treatment outcome. So you need to assess your patients and make sure they don't have any pre-existing medical conditions or oral conditions, and this must be also taken into consideration with do they have good bone volume and quantity, and do they have good access for surgery, the location of the implants. Remember, implants in the posterior regions of the jaws have higher failure rates than implants in the anterior. So again, if you're starting out and relatively fresh to implantology, then place your implants in the anterior zones. Access is much better and the bone quality and quantity is often much better in these regions. Do not try to undertake complex procedures involving immediate implants immediately loaded in poor quality bone, because if you take this approach, you're doomed for failure. Statistically, the probability of osteodisaffiliation is very high, and the probability of achieving osseointegration is equally very low. So now, with competency in mind, we can look at clinical experience. How many cases have you actually restored? What is your knowledge of the system? What is your understanding of osseointegration? Poor case management, pre and post-operative care. Have you remembered to prescribe antibiotics? Haven't you given them in the correct dose at the correct time and the most appropriate antibiotic? Are you able to recognize problems when they occur, diagnose them, and provide the appropriate corrective and remedial treatments? If not, you can expect osteodisaffiliation. Poor infection control, the way in which your instruments are cleaned and managed, packaged and presented, and the way in which you manage the procedure. Do you cause thermal damage to the bone or traumatize the bone in some other way? Remember, you're relying on the biological healing of the bone to produce your secondary fixation, your osseointegration. If you have killed or damaged the osteoblasts or osteocytes in the area, then you're not going to get osseointegration, you're going to get osteodisaffiliation occurring. It's also worth reminding yourselves that when you place the implant, the primary fixation may be excellent in good quality bone. But if you have damaged the bone in placing that implant, perhaps you've underprepared the site too much to try and improve the initial primary fixation. This has caused compression necrosis to occur in the bone. And in fact, what you end up doing is over a period of time, you actually lose primary stability as the bone dies. So now you've immediately loaded an implant, you've placed it under quite a deal of pressure, which has caused the bone to necrose. In fact, what you have now got is osteodisaffiliation, and the bone is no longer able to take the load, and you have loss of an implant. So over or under preparation of the bone is very important. Obviously, if you over prepare the bone, then this means that the implant is actually not in contact with bone. It's actually lying loose in the osteotomy site. There is a large gap around the implant, and at this point we have osteodisaffiliation. There is no contact whatsoever between the bone and the implant. Now, this doesn't mean to say that if the implant is protected and is sufficiently stable, as is the case with perhaps immediate placement, that bone will not form around the implant to give you osseointegration. So, but that is a different scenario to placing an implant and immediately loading it when you've not got bone around the implant in the first instance. Prosthetic management. Well, again, we're looking at clinician experience and competency. If you don't place enough implants, if you don't manage the occlusion, If the occlusion is high, then you're going to have bone breakdown and you're going to get osteodisaffiliation occurring. In this respect to immediate placement, remember, with immediate placement and loading, you are submitting the bone to occlusal loads from day one. Now, if these occlusal loads are not controlled and balanced, then we know that this will result in damage to the bone, and your chances of osteodisaffiliation and bone loss, of implant and bone loss, will increase dramatically. If you have in your practicing life managed to place crowns that need no occlusal adjustment, or you have never got the occlusion incorrect, then you're obviously going to be very suited to immediate loading of implants. However, if it is the case, as with most of us, that we've always had crowns that need adjusting, or we have sometimes got the occlusion incorrect and the patients come back with a fractured or broken restoration, if you fall into that group of clinicians, as I do, then be very careful and cautious when it comes to immediate loading of implants, and also ensure that your laboratory is also as equally adept at managing the occlusion as you are. So poor case selection. Right from the outset again, if the patient is not suitable, either on grounds of medical condition or lack of quality bone, then they should not be treated. Implant therapy is not necessary for their ideal treatment, and it may be better to provide them with a bridge or some other conventional restorative means. Poor prosthetic design and fit. Again, this is down to experience, not just of the clinician, but also the dental technician. If your lab is not skilled at delivering good fits and high precision implant work, then you should not be using them. And finally, occlusal trauma or overload. This is particularly significant if you're intending to do immediate loading, and again, has the patient got a history of bruxism? If the patient has a history of bruxism, perhaps immediate loading a prosthesis is not the best option in their case. So now, what are the successful criteria for osseointegration? Well, Albrechtsen in '86 published success criteria during the first year after abutment connection. 1 mm of marginal bone loss is allowed, followed by 0.2 mm per year thereafter. So this is often referred to as the gold standard for implant success. Again, it's important to understand that this was published in regards to a particular system, and also it reflected a particular very strict surgical and restorative protocol. Nowadays there are a myriad of different implant systems, as there are restorative solutions and surgical protocols, and these all impact on success criteria, and the success criteria will vary from implant system to implant system, from protocol to protocol. All these criteria will produce, no doubt, functioning implants, but the criteria on which success is based will vary depending on the type of implant and the protocol used. So although this is a good benchmark for determining success for our implants, it is not the only criteria which should be used, and different systems and different approaches will use slightly different criteria. More updated clinical parameters were published following the PISA consensus conference, and these parameters are perhaps more relevant in today's clinical environment, where we are immediately loading our implants. So we're looking at pain, and this can be the total absence just the absence in function. Sensitivity, occasionally we can have sensitivity from our implants, but they're still firm and functioning, or we can have pain in function. There's different levels and degrees of mobility. It can be present or absent, but again, up to 1 millimeter may be permissible in some situations. Probing depth is something which becomes irrelevant when the implants are restored, and also if you're doing immediate loading protocols, as is bleeding on probing and the presence or otherwise of exudate. And finally, we have the radiographic parameters, which is a peri implant or peri-fixture radiolucency. So you can see these clinical parameters are far more extensive than those published by Albrechtsen in '86, where he was looking at the radiographic changes in the marginal bone level. So what are the signs of osteodisaffiliation? Well, any form of pain or discomfort, whether it be on trying to rotate the implant, on exerting lateral or horizontal loading, or actual loading on our implants. And the actual loading can also is in the vertical plane, of course, but it can also be an extrusive as well as intrusive forces. So any kind of discomfort or sensation related to any kind of load or pressure in these various directions. We also have mobility, and again we can look at mobility in the various planes, and of particular concern obviously is mobility, rotational mobility, because this is very indicative of breakdown of our bone contact. Sign of infection, exudate, followed by suppuration. Suppuration with bone loss is always an indication of peri-implantitis. Progressive marginal bone loss, whether this is detected by probing or by the use of radiographs. And finally, a peri-fixture radiolucency surrounding the entire implant. Obviously this is completely indicative of osteodisaffiliation. There is no longer any kind of contact between the bone and the surface of our implant. Now, progressive osteodisaffiliation. This is where the contact between the bone and the functional implant is degrading over time. And in the past, this was also termed as a failing or ailing implant. It's difficult to distinguish or differentiate between an implant which is slowly losing its attachment to the bone, or slowly or progressively undergoing osteodisaffiliation, or one which is actually healthy and osteointegrated, as the implant is still firm and functional, and there's an absence of pain. Now, what are the signs of progressive osteodisaffiliation? Well, the main sign is progressive and steady marginal bone loss, as seen usually on radiographs, but you may detect it from probing. But the most common way of discovering this is on annual radiographic review. There may or may not be an exudate or suppuration, and in the absence of bone loss on its own, this is not a sign or indication of osteodisaffiliation. And the old term of an ailing implant may be better used, in which we basically maybe have a soft tissue infection, a mucositis occurring, which is manageable. So just the presence of inflammation or perhaps suppuration is not necessarily an indication of progressive osteodisaffiliation. Also, with this situation, there is no pain, mobility, and there is no perifixural radiolucency. So there may be evidence of crestal bone loss or marginal bone loss, but you will not have a peri-infixual radiolucency. This radiograph amply shows the radiographic signs associated with osteodisaffiliation, in that we can see on the coronal section of the implant there has definitely been bone loss in these areas, and also in these areas here some marginal bone loss as well. However, more apically, the implant is still very much osseointegrated in these areas here and here, and is showing no signs of osteodisaffiliation. So this is an example of progressive osteodisaffiliation. Now, if we look at the clinical situation, we can see, apart from the accumulation of plaque or media alba in this area, the tissues themselves look particularly healthy. There's no evidence of inflammation, and there is no bleeding on probing. So exudate bleeding on probing is not an indicator for progressive osteodisaffiliation. However, the radiograph shows bone loss, and the fact that the threads are exposed on the labial surfaces of the implants is definitely an indicator that we have a progressive disaffiliation. And in fact, what we have here is a peri-implantitis, which is the infective process which is causing our loss of osteointegration and will ultimately lead to the loss of our implants. Now, the management of osteodisaffiliation is quite difficult, as the situation and the treatment protocols are unclear and have not been established by evidence in the literature. So first of all, we have to decide whether we have osteodisaffiliation prior to function, which means we never achieved osseointegration, and this could be the situation with immediately loaded implants, or whether we have a progress of progressive osteodisaffiliation, which means that we did achieve function of the implants in some form, whether it be a mechanical fixation, or whether we had in fact developed not osteofixation but osteointegration, and whether it is a breakdown of the osteofixation or a breakdown of our osteointegration. So it will depend on the severity and etiology of the progressive osteodisaffiliation. So ultimately we have to decide whether we can preserve our implant or whether we need to remove the implant in order to prevent further bone and tissue loss. So what are the causes or etiology of progressive osteodisaffiliation? So we have peri-implantitis. Now this is an infective process, it's peri-implant disease, and basically this is biological in nature and it's loss of integration. So in this situation, the implants were osteointegrated and were able to carry load because of the nature of the osteointegration, the nature of that biological contact between the bone and the surface of a load carrying implant. Now we can look at occlusal overload, and this is biomechanical, and it can be either due to a loss of osteointegration or of osteofixation. If our implants were immediately loaded, then by its very nature those implants were never osteointegrated. They were relying on a purely mechanical fixation of the implant to the bone, or osteofixation, which is nothing to do with any biology, or if it's a more traditionally restored implant or implant driven protocol, then the fixation of the implant is due to biology and its osteointegration. So the implant is carrying load or transmitting load to the bone, either by means of osteointegration, the biological connection, or osteofixation and mechanical fixation. And occlusal overload can have a significant effect on both of these, leading to progressive osteodisaffiliation or the loss of our bone contact. And then finally, we can have a combination of the above, in that we could end up with an osseointegrated implant, which then is overloaded and starts to lose bone, and this makes it vulnerable to bacterial infection and peri-implantitis. Or alternatively, we could have the situation where we have a peri-implantitis becomes established. This results in its very nature in bone loss, and this alters the implant crown ratio and then predisposes the implant to occlusal overload. So as you can see, the etiology for progressive osteodisaffiliation is quite complex in its nature, and it is multifactorial. When it comes to infective progressive osteodisaffiliation, the main cause here is perhaps peri-implantitis, and this is a biological cause for our osteodisaffiliation. And there is no evidence or recognized treatment protocol for this condition. Many treatment protocols have been devised or advocated, but there is no clear-cut treatment regime for the management of implants with peri-implantitis. Once an implant has peri-implantitis, it may be possible to prevent its progression and stabilize the situation, but you will never be able to treat or regain the situation to how it was before you had the peri-implantitis. So it's an untreatable condition. There is no evidence that the more complex and expensive therapies are any more beneficial than simple therapies of subgingival mechanical debridement, which is the therapy I tend to favour, but these therapies must be carried out in combination with antibiotics. Follow-up longer than 1 year suggests that recurrence of peri-implantitis can occur in up to 100% of cases, and this is a chronic disease, so retreatment is to be expected. And this is what I found from my own treatment. Occasionally I'm successful, but more often than not patients return within a year and need further treatments, and a point is reached whether one has to decide whether it's worthwhile keeping the implant and risking further bone loss, or removing the implant and starting again. Also to be borne in mind is that the surface of the implant exposed or out of the bone is contaminated with bacterial byproducts and pyrogens, and this means that reintegration or neo-integration is impossible and cannot be achieved. So once you have a contaminated implant surface, it is not possible by any means at present to decontaminate that surface back to the same type of surface as came in the original box before the implant was used. So our problem with trying to reverse this type of progressive osteodisaffiliation is the fact that we have a contaminated surface, which doesn't lend itself to neo or re-osteointegration. Now, occlusal overload causing our progressive osteodisaffiliation is perhaps a better call, in that we can correct maybe the occlusal causes for the overload either by changing the design or the manner in which the occlusion is managed. Also, we can look to placing additional implants to share the load more evenly, or perhaps if we've got single implant restorations, we might decide to splint them. All these are acceptable ways of managing occlusal overload. We may provide the patient with a night guard as well. So again, a number of ways of managing occlusal overload. Now, unlike peri-implantitis, a regeneration of bone is perhaps more predictable and a more viable prospect, because the bone loss in this situation has been lost through occlusal trauma, through overload of the bone, causing breakdown and bone necrosis. The loss of the bone has not been caused through bacterial byproducts or bacterial infection or enzymes. This is purely a mechanical overload beyond the tolerance that the bone is able to withstand, such that it breaks down. So a much better prospect for the management of our progressive osteodisaffiliation is one which is due to occlusal overload, because grafting may still be a viable option, because we don't have to deal with the contamination and byproducts produced by a bacterial infection. Well, the clinical considerations when looking at progressive osteodisaffiliation are: you have to balance the cost of early loss of your implant restoration against the subsequent cost of its replacement, possibly combined with the need for grafting. And when I talk about cost, I'm not just considering monetary cost. There's also a biological cost, in that you will lose bone, and this is costly to regenerate, and as I've said, it is not predictable. For some reason, many dentists feel that grafting bone is as easy as placing an occlusal filling. No, it's far more difficult. It's a biological process. It can become infected, it can be rejected, there can be donor site mobility, there can be all sorts of issues with grafting, and at the end of the day, the bone you develop or generate can be poor quality bone, of questionable biological stability and reliability. So early diagnosis is very important, and you have to decide whether persevering and trying to save the implant is worth the potential cost of its eventual replacement, both monetarily and biologically. So the acronym to remember here, or one of the 10 implant keys to implant success, is early intervention for prevention. So what is the take-home message of this presentation? Well, I would like all those dentists engaged in implant dentistry, regardless of experience, to always exercise caution. Be very careful in the selection of your patients. Be very careful in the management of your patients. And be very careful in the way that you maintain and provide aftercare for your patients. Do not be tempted to undertake ambitious treatment plans or protocols. Remember, early loading, immediate placement are very demanding protocols. They're very complex protocols, and the risk of implant failure or implant loss is much higher with these protocols in inexperienced hands. So if you have not got experience of restoring at least 50 or more implants, then I would not advise that you attempt to either place full arch restorations, and definitely avoid complex procedures such as sinus lifting and immediate loading, as your failure rate statistically will be far higher. And with these advanced procedures, the complications can be far more serious and debilitating for the patient if it subsequently fails. Well, what are the take-home points following this presentation? Well, I think it's important to remember that osteodisaffiliation and subsequent loss of a functioning implant is the result of multifactorial factors. Seldom is it just the result of one factor, but a number of either independent factors or main factors, risk factors, which are contributing to this breakdown of the bone contact or failure for the bone contact to even develop in the first place. So this is osteodisaffiliation, either the loss of a contact between the bone and a load-carrying implant, or indeed the failure to actually develop one in the first place, or at least maintain one. Now, what is the main overriding factor in all of this? Well, I think if we have to be honest with ourselves and understand that ultimately when we lose an implant, it's iatrogenic. That is, it is down to some failing on the part of the dentist, either occlusal failing, or possibly a management failing, or a surgical management failing. Ultimately, all these factors are in the hands of the dentist, and it starts right from the very beginning. Patient assessment. If the patient has occlusal problems, well, then the restoration is going to be prone to occlusal overload. If the patient has social issues, addiction issues, or medical issues, again, it's up to us to select the patient and decide whether they are suitable for implant therapy. If the patient presents with insufficient bone or bone of poor quality for whatever reason, again, it's up to the dentist to make the decision. Are these patients suitable candidates for implantology? So, remember, at the end of the day, you are ultimately liable for implant treatment. You are providing an implant. It is an elective treatment. The patient isn't suffering from any disease or condition that needs to be treated. They are asking for implant restorations, and it's your duty to ensure that you have properly assessed the patient and manage the patient throughout the process. And bear in mind that if you do get osteodisaffiliation for any reason, then ultimately it's your responsibility to manage.